Bye, merci beaucoup. Alors, bonjour, on va commencer tranquillement. Merci beaucoup d'être présent aujourd'hui. Bienvenue au Midi éthique. On est très heureux et très fiers d'accueillir aujourd'hui avec nous un conférencier de renommée internationale qui va venir nous parler d'un sujet qui nous intéresse beaucoup. Avant de commencer, je voudrais remercier Dr. Annie Janvier qui a vraiment rendu cette présentation-là possible, également Catherine Bédard et son équipe du CHUM. Qui nous ont aidés aussi au point de vue technologique pour cette conférence-là. Donc aujourd'hui, on tente avec la technologie Zoom, hein, donc c'est web diffuser la conférence. On aura la chance à la fin de la conférence de prendre des questions ici à l'interne, mais aussi des gens qui sont sur le web. Donc pour ceux qui sont sur le web, vous avez à écrire vos questions dans le chat, et, ou de lever la main en fait. On a un administrateur là, qui est sur le web aussi, là, qui va sûrement ajuster le son aussi tout au long. Donc, je vais vous, sans plus tarder, vous présenter notre conférencier aujourd'hui. OK, donc c'est ça. J'ai un commentaire dans la salle que les gens sur le web, idéalement, vous mettent sur mute pour qu'on puisse avoir un son plus optimal ici. Donc, je vous présente notre conférencier aujourd'hui qui est Dr. Edouard Verhagen, qui est pédiatre au Centre médical universitaire de Groningen. Je ne sais pas si ma prononciation est bonne. Il a obtenu son diplôme en médecine et son doctorat en droit à l'Université d'Utrecht et a complété sa formation spécialisée en pédiatrie à Amsterdam. Sa thèse de doctorat a porté sur les décisions de fin de vie en néonatologie. Monsieur Verhagen a publié plusieurs articles scientifiques sur la prise de décision éthique et sur les soins de fin de vie. Il est aussi l'auteur, un des auteurs du protocole de Groningen sur l'euthanasie des nouveau-nés. On est vraiment très content de l'accueillir aujourd'hui. Merci beaucoup d'avance.
Okay, good afternoon, everyone. My French is holiday French, I must admit. So my presentation will be in English. I have some French slides, and I'll explain why they're in French, and I hope that it helps you get the message forward. And if you have questions, either during my talk or after my talk, and you feel more comfortable posing them in French, do it. I'll try to immediately understand it. If not, I look to Annie or to you to help me translate. So don't withhold your questions just because you think that your English might be less than perfect. My English isn't super perfect. My native language is Dutch, but I figured that in Dutch no one will understand. I make mistakes too, so you're invited to ask questions in the language that you prefer. Okay, so there's a lot to share with you, a lot of information about the developments in the Netherlands, and I've tried to structure it in a way that we're going to talk about end-of-life decision-making in adults as well as in newborns, and we'll talk about pediatric population as a whole. There are some interesting similarities, there are some differences between those two fields, and I think it's fair to say that the Dutch have been obsessed with death and dying for many, many years. And you're going to see a little bit of what this obsession has resulted in. And it probably also tells you a bit about our culture, our way of dealing with obsessions and dealing with death and dying. So, first of all, let me see how I get to the next one. This one.
Ah, ça marche pas.
Ça marche pas. Is the hospital sabotaging my presentation?
C'est ça, on avait tout fait les tests. Là, y a-t-il le audiovisuel en arrière? On l'a fait très chaud. Ah, non, je l'ai. On a notre texte en ligne. Allez-vous... je te passe en plan. Okay.
Allô?
Yep. Well done. It's good. Thank you, Antoine. All right, just to give you a bit of a perspective, the almost invisible orange spot is Holland, and the green country is your country. Interestingly, we have 17 million inhabitants, and I think you only have twice as much. So, but we're very much condensed on a very small part of the country. We're in Europe, as most of you know, and Belgium and Luxembourg are our neighbors. They're interesting neighbors. They too have organized adult euthanasia, and we'll be talking about that too. So if you ask me why are those three countries doing this, I have no idea. But it is geographically, they're connected. Tiny country, 70 million inhabitants. We have a good general access to high quality of health care. We have public hospitals, hardly any private care. There is mandatory health insurance for all inhabitants. So everyone is insured. Full cover of terminal and palliative care. High quality care at home, in nursing homes, 2,300, hospitals or hospices. Very important part of our healthcare system is the GP. Everyone has a GP. I have a GP. If I have a problem with me or my kid, or I go to my GP, he knows us, he knows my family, he knows where I live, what I do, etc. So a very important part of the healthcare is the filter that the GP can make. Who is he going to refer to whom is always GP decision. And they take care of 68% of cancer patients dying at home. Dying at home is the norm in the Netherlands. We have many consultation teams, adult consultation teams, and since a few years, we also have pediatric palliative care teams in the university hospitals. So that is the basic knowledge about the Netherlands. This is what we're known for, the tulips and the mills. We're also known, but not as positive, for our euthanasia, and we're often, but not everyone is happy with the euthanasia policy, and I'll try to explain a bit of how we approach this issue. First of all, it's important to at least give you some definitions. If we talk about the end of life, people, generally adults as well as pediatric patients, need some comfort-oriented care, and decision-making is frequently done. Decision-making in our Dutch literature is divided in three end-of-life decisions, three types. One is the decision to withhold or withdraw life-sustaining treatment. This is the decision that is most frequently taken, the most important one. Second one that is important to us is the decision to use comfort medication, morphine, midazolam, other similar medication that may shorten life. And the third one is the decision to provide euthanasia. And we'll focus on all of them. So euthanasia, very important for the Dutch, is death on the patient's request. Okay, death caused by a drug that is administered by a physician to end the patient's life at the patient's explicit request. So I was reading about the developments in Canada, and I noticed some similarities and some differences. The terminology is different, as you can see. You're talking about AMM. We're talking about euthanasia. My talk will be about euthanasia. If I talk about newborn euthanasia, to Dutch people, they would immediately say that is not possible. You cannot say newborn euthanasia because a newborn can never explicitly request. That is a very important point to make and to keep in the back of your mind. So between us, between the Dutch, we will not speak about newborn euthanasia. We'll speak about deliberate life ending in newborns, etc. But in many other countries where I present, I talk about newborn euthanasia. But there is something weird about it, because euthanasia is the patient's wish, and the patient, our patient, is a newborn who has no wish, no explicit wish. We do not know that wish. And we allow parents to speak up for the kids. So, an obsession, really. We have been investigated the opinion of the Dutch public for more than 50 years, and we continue doing it. And since 1966, it is well known and and it's published everywhere, that the majority of the population is in favor of euthanasia. This has been a topic for many, many years. There's also a willingness amongst doctors to perform euthanasia. You can, if the public wants euthanasia, but there's no one to perform it, it stops. But both groups are in favor of euthanasia. And this slide shows you a little bit of the history of how we came to legalize euthanasia in the Netherlands. And the first cases of patients asking for euthanasia are even before 1985. They're documented, they're published, and they were the reason for a state commission to make a report saying we should probably, as a country, allow euthanasia in specific situations. We see that it is happening in practice. We should be able to organize it in a way that is good. So it was done already. It wasn't prosecuted, it was accepted. And gradually the government started to be involved, and first by announcing this state commission, and there were all kind of wise gray people saying that we should allow it. And from that moment on, from 85 on, it was decided that we wanted to monitor end-of-life practice. So the first monitoring started in 1990, a huge survey among doctors combined with a death certificate study, a nationwide death certificate study, to find out what is actually going on. The surveys were anonymous surveys amongst doctors who were protected by the law, so they knew that whatever they would say, they could never be prosecuted for what they said. So they were free to say whatever they had done or had thought or considered in that patient that they ended the life of. So that was our way to get insight into decision-making and actually the performing of euthanasia. Not only euthanasia, but also the decision to withhold or withdraw life support. How does it really work? What are the considerations? What happened afterwards? All those questions are in those surveys, and it gave us a good insight. First time was 1990. Then there was a review committee. The government decided to make a review committee. They said, okay, although it's probably against the law to kill a person on his request, we allow it, we will not prosecute it, but let's make a way to review those cases. And the first step was having those cases reviewed by the public prosecutor. That didn't feel very safe for doctors. So in 1998, they decided to change that and make the review committee a multidisciplinary review committee, consisting of doctors, physicians, legal people, ethicists, and others. A second study, I'll show you some interesting information from those studies later. A third study in 2001, and then in 2002, after several court cases had been held searching for norms for euthanasia, ultimately the Euthanasia Act was adopted. So there was a practice even before 1985. People started to get interested in regulating it. There were court cases to find out what the legal people would say if they had a case like that, what their opinion would be. And ultimately, this resulted into a law in 2002. Then in 2005, the first survey again, what happened after legalization of euthanasia, very important. So there was an intervention, the law, and what did it do to practice? And we continued surveying medical practice until the last time, recently, 2015. It wasn't only adult practice, it was also newborn practice. Newborns defined as infants between 0 and 12 months. And I'll show you some data. So what was the ethical justification of the euthanasia at that time and still for the law? It was self-determination. People should be able to determine their own death, their own future, they should be able to make their own decisions about life and death. Also, there was the idea that it was the good thing to do. It was also seen as a responsibility to allow this possibility to people. So it was felt, in addition to that, as a kind of a way to show compassion. What sense does it make to suffer if you know you're dying? If you don't want the suffering, why can you not ask for your own death? So that was the idea, an act of compassion, an act of care to allow euthanasia. Interestingly, and Annie told me, stressed that point, apart from the first justification, self-determination, those who are against euthanasia would probably use the same principles to be against euthanasia. So it is all very relative. But for the Dutch, self-determination in combination with compassion for people were the main reasons to ultimately legalize euthanasia. There was also a broader perspective, a political perspective. In politics, they said, if there is a broad acceptance of euthanasia, we should be able to make the next step and make a law. Also, they said, there are different views on justification and extent of euthanasia. So we should provide, the lawmaker should provide a way to make it good for all people, those who want it and those who don't want it. So those ingredients were put into the mixer, and that made the 2002 law. What does the act actually say? It says a physician may perform euthanasia if he or she is convinced that the patient made a voluntary and well-considered request. So there has to be a request, which is voluntary and well-considered, but the request is not enough. There's also a physician that needs to decide, am I going to perform it? Not only the request is important, there has to be unbearable and hopeless suffering with no prospect of improvement. The patient needs to be well informed about the situation and the prognosis. There's no reasonable solution to relieve the suffering. There's independent physician needed who must visit the patient. And the act must be performed with due care. So the point 5, the independent physician, is also organized. There is a group of physicians that you can call. Suppose I'm a general practitioner. Most euthanasias are done by general practitioners. I would call those physicians, who are often also general practitioners. And they come, they visit the patient, they visit me, they give me support, and they try to talk to the patient and find out, is this a reasonable request, and would it be reasonable to go along with it? Then they would advise me. Their advice could be, this is a reasonable request, you should be able to do it. It is within the requirements. Or they would say, our advice would be, don't do it. It will always be my decision to either do or don't do it. And there are cases where physicians perform euthanasia against the second opinion. They have to explain later, afterwards, why they did it, but they're rarely prosecuted. There are sometimes very good reasons why they did it. So that is the construction of our Euthanasia Act. You can ask for it, but it doesn't mean you'll get it. There are requirements that needs to be fulfilled. Most of them are in the law. These are in the law. Some are outside the law. Additional requirements for the physician, for instance, are that he needs to or she needs to take control if request is made. You cannot hide. You have to take control. If you cannot provide it, you should be able to refer to a colleague, general practitioner, who's prepared to do it. You must be resistant to improper pressure. You have to keep a professional distance, and you have to communicate with and guide other care providers and the family. It's quite a task. So if you look at those surveys, one of the things that we know is happening in our country, and the colored bars represent the surveys in 1990, 1995, 2000, that death in adults is preceded by an end-of-life decision in around 40% of cases. And it has gradually increased to 60% of cases. The decisions made are withholding or withdrawing life support, giving medication that may hasten death, or providing euthanasia. If you look more into the details, you would see, for instance, that withholding or withdrawing occurs in around 70 to 20% of cases, and it has remained stable over time. So in 1990, it isn't much different from 2015. Medication that may shorten life has increased. So one of the reasons to monitor this is to find out what is happening. If you find out that there is an increase, you need to study it. So the government would supply money to find out what is the reason that we are doing this more frequently. We're giving more medication. And the answer in this situation was, probably it's a good sign, because people are more aware, physicians are more aware of the need to, for instance, treat pain with medication. And this was a good explanation. The fear was that people would actually euthanize patients, but giving it a different label. By giving a lot of medication, stopping the respiratory drive, it would actually be killing, but they would label it as giving medication that might hasten death. Interestingly, euthanasia, it's a very small proportion, and it has remained a small proportion. There is a slight increase between 2010 and 2015. It's around a little bit less than 4% of deaths in adults is by euthanasia. New categories that are added to the surveys are deep sedation, palliative sedation, also because there was a fear that people would be scared away from the administrative issues that come with providing euthanasia and would just give palliative sedation, for which you don't need approval of the patient, for which you don't need there is no review procedure there. Palliative sedation is seen as normal medical care without specific reviews or rules. There are protocols, but no reviews. Same is true for withholding or withdrawing. If a team decides to withhold or withdraw life support and the patient dies, there will be no review. It's seen as natural death. Euthanasia is not seen as a natural death. There are a lot of procedures that come into development. If you've performed euthanasia, you must report, there will be review, you have to fill in a lot of forms, and you'll have to talk to the committee often. No eating and drinking is the last category. Increasingly, old people decide to stop eating and drinking themselves. And the question was, why are they doing this? Is it because they actually want euthanasia, but the procedure has become too problematic? And so we studied this. There was enough money, again, from the Ministry of Health with the specific question, research this, find out why this is happening. And it turned out that it's a change in the population, in the elderly population. They simply want to control their life and death. And one simple way to do it is simply decide for yourself to stop eating and drinking. So it isn't an escape mechanism as far as we know. It is a voluntary choice that people make because they want to be autonomous decision makers about their own death. Okay, so this is increasing, and we're very curious to find out whether it will even increase more. If any of you want to read all the details about all the euthanasias every year, you can go to the website of the review committees. They have to publish all the details every year, and the reports are in Dutch, in German, in Spanish, and in French. So you will be able to read all the details and also the comments of the review committee. And I've taken a few slides coming from the annual report in 2017, where all the cases are brought together and all the decisions about the cases are brought together. And those slides, I think, excellently show that of all cases, the vast majority is actual euthanasia. So a patient requests for euthanasia, gets the euthanasia. It's not physician-aided suicide. It's very rare in Holland. And sometimes it's a combination of both. So if you talk about euthanasia in Holland, you don't talk about physician-assisted death. It is euthanasia as defined in my earlier slides. Okay. So what are the diagnoses of those people requesting for euthanasia? Here, and also I think in Canada, the main group is cancer. So it's the brown group. Nervous system problems is second. And there are some interesting colors that you might wonder about. For instance, look at the green one, the light green one, dementia. For the Dutch, dementia is a reason to ask for euthanasia. Frequently, you have to have an advanced will that says, if I become demented, I want to die. So you have this advance directive, you talk about it with your physician, and then in this period where dementia has started and you're not totally demented, the physician will end your life. Theoretically, it would be possible to end the life even in the latest stages of dementia, but you will not find doctors prepared to do it because, as a kind of a simple picture, nobody wants to end the life of a laughing person who is happy, who looks at television, and who's happy to see you. It's impossible to introduce an IV line and give medication and make the person dead. So there is dementia euthanasia. It's always in the gray zone between it has started, but it's not the full picture. Not because it's not the wish of the patient, but because you will not find a physician who will do it. All right, so it's a small proportion. I'll give you the exact numbers a little bit later in another slide. Accumulation of old age phenomena is an interesting one. So if you're older and you have all kinds of troubles that make your life unworth living, and you've decided that it's too much for you, you can ask for euthanasia. This was a large debate, a huge debate, because each of those elements apart are small elements, and nobody would understand a request for that reason. But if you take them all together, for some people, they would say, this is too much for me to bear, I want to die. So a small group of euthanasias is in this group. Psychiatric disease is hugely debated, even now. When is depression severe enough to be a reason for euthanasia, and who decides on that? Do you have to be like treatment-resistant depressed? And when are you treatment-resistant depressed? Or can you also request for euthanasia if you have a beginning stage of depression? Those are the discussions that are ongoing, and there has been an interesting advice of the scientific a group of psychiatrists trying to flesh out what kind of diagnosis would never be good reasons for euthanasia and what are considered to be potential reasons. So this is still in development. What about the ages? As you can see, most of the people dying from euthanasia are old people. The biggest group is 70 years and older. I'm just focusing on the green one, which is 30 years and younger. There are 3 minors in that group. And that makes you realize that the euthanasia law basically says everyone who is 12 years and older can request for euthanasia. So it means not only 18 plus, it's 12 plus. So in theory, the 12-year-old needs to be accompanied by one of the parents, and they have to consent in the request, and then the request can be a valid request. The law even sees to the situation that the child and the parent do not agree. And the law says then we follow the child. So interesting, especially for some countries in the world, it is unimaginable that a 12-year-old has so much autonomy. But for the Dutch, it is very logical because all our healthcare laws are based on this mechanism. 12 years is the age on which children can decide about their own health and future. So for us, it's logical. For many others, it's scary. So those minors, I've used this picture to show you that the minors that have received euthanasia in the last, 15 years, all had end-stage cancer. Some of them were as young as 12, but most of them were almost 18. And it sometimes helps to take away the magic. Wow, so everyone can ask for euthanasia. All the kids are murdered in Holland. Nonsense. In those 15 years, very few cases of end-stage cancer. And if you would see the children, you would totally understand why they feel that they're suffering unbearably. All right. The picture comes from a Canadian report. This is the report that I found on the internet. It's a super interesting report, recently published, I think, in 2017. It's about the mature minors. Mature minors is not a terminology that we use in Holland, but it tries to give you an overview of how the end-of-life requests could be approached in Canada, considering your own developments of legal and medical stuff, but also put against the developments in Holland, in Belgium, and other countries. So it's a super interesting report with excellent slides. Most of the euthanasias are done by general practitioners, as you can see here. The blue part is general practitioners. And from my perspective, I work in a very large university hospital. We do very few euthanasias in our hospital in adults. And I think we're pretty clumsy in it too. So I would never advise people to come to our hospital for euthanasia. Go home. Your general practitioner is experienced, is better. He knows exactly who to mobilize, how to organize it. And for instance, my mother-in-law asked for euthanasia, and she's dead now. So I saw firsthand how it was organized. A very wise and good general practitioner organized the ambulance people to come to introduce an IV line because the general practitioner wasn't certain about her own skills. The ambulance people said, okay, we do this all the time. Hop, it's done. And then the procedure was performed in the presence of the whole family. I mean, the whole room was filled with everyone. It was sad, but it was exactly what she wanted, what she envisioned. So that shows my kids were there too. So they know about euthanasia. They talk about euthanasia in their schools, amongst each other. And it is part of our society. Everyone knows about it. Maybe not all the details, but everyone has a grandma or someone else who was who received euthanasia or asked for euthanasia or was considering euthanasia. It is part of what people talk about. This is important to keep in mind if we talk about newborn euthanasia. So where do they die? They die at home. Most of them, it's a like orange, brownish color. Most people in Holland die at home. It's seen as the best place to die for many reasons. And so euthanasia is also done at home by the general practitioner in the presence, frequently, of your own family and friends, and the referent and the priest and whoever you want to invite. Okay, so hospital is rare. If you look at the numbers, about 150 deaths every year in Holland, and about 4% is euthanasia. The rest is either just death or withholding, withdrawing, etc., as I've shown you. There are more requests than actually are performed. So not all the requests are really leading to euthanasia. And in those annual reports, you'll find a explanation for each denial, and it's super interesting to read. Mostly cancer, mostly GPs doing it. We're talking about advanced will and dementia. So what if you, in your autonomy, want to die as soon as you're really demented? Why is it possible that you're not receiving your euthanasia when the dementia is considered to be too advanced? So that is for lay people, that is very difficult to understand. So this is what we're talking about. Psychiatry, I've told you about it. Fulfilled life. We had a senator, a very famous senator, who asked his general practitioner to end his life. He was old, and he said, "My life is fulfilled. I've done everything that I wanted. I don't see any use in, I'm not depressed, I'm happy, but I'm finished. I finished my life. It has been perfect. So I want to die." The general practitioner did it. He ended the life of this person. He did it according to the rules. So he reported, it was reviewed. And in the review, the review committee said, well, there is no law or rule that says that you can provide euthanasia if someone is finished with living. So there was a prosecution of this general practitioner, and it went up to the highest court, and the highest court said, no, this is too much. We are not going to extend the rules to that. But after that, gradually, new developments came, and it wasn't called fulfilled life. It was more constricted as all the problems that older people can have in their lives. If you put them together, they can cause suffering. They should be a reason for euthanasia. So through the back door, the same arguments are now still on the table, and there are reasons for euthanasia that the new review committees will allow, but it's rare. I think it's like 200 cases a year or something. Okay, so this is it's a dynamic process. That's what I wanted to say. It's not like the law says this, and now the next 25 years, it is like this. No, it's constantly developing. Sometimes requirements are made more heavy, sometimes they are lighter, and it's changing all the time. So here you see some data. Simply said, it has been cancer all the time. So from 2011 to 2016 and onwards, it's mainly cancer. Dementia, around 2%. And it's been like that more or less all the time. Psychiatric disease, 1%. So it's not like numbers of depressed people that are euthanized. It's very small number. Accumulation of various old age affliction, that's the new label. It's like 244 cases every year. They're all reviewed and not prosecuted. And there is a remaining group. Let's go to the newborn, because there is a problem there. As I told you, and you can think of this by yourself, a newborn will never be able to request for euthanasia. And we even don't always know when there is suffering and when it's unbearable and how it's unbearable, etc. So we've done those surveys in the 5-year surveys also in newborns. And this is just to show you that until 2005, this was the picture. 40% of deaths in adults was preceded by an end-of-life decision, either withholding, withdrawing, medication, or euthanasia. And in newborns, it was always slightly higher, around 60%. This is 0 to 12 months. From the first surveys onwards, we knew that there was a blue bar also. From those anonymous surveys, we knew that a percentage of deaths in newborns was blue. Medication, shortening of life was explicitly intended. We didn't know who did it. We didn't know which children were involved. We simply only knew that if you ask doctors to tell you what they did, you'll find a small blue bar. There are babies who are actively ended, their lives are actively ended with medication. There was a large European study confirming this. This is a Euronic study. They asked European doctors working pediatricians in many countries, have you ever been involved in either withholding or withdrawing, life support or euthanasia? And only the French and the Dutch doctors would say, yes, we were during our life involved in euthanasia cases. So we knew for many years that it was there, but we didn't exactly know why and how. It was kind of semi-hidden. We knew it was there and it wasn't prosecuted, but we didn't know the details. This is Bente. It's a patient that was admitted, referred to as from a very small hospital close to Groningen. And Bente was not very ill, but she had a funny, interesting skin disease that the doctors didn't know what it was. So they referred her to us, first gave her a nasogastrical tube, and asked us, could you find out what it is? It doesn't seem to be infection. Can it be an autoimmune disease? What is it? It turned out to be epidermolysis bullosa, which is a horrific disease that comes in many varieties. So you can have a very severe form that is lethal. All children die at young age, and you can have a very mild type. Bente had the severest type that basically causes the skin not to attach to the body. So if you touch the skin will come off and there will be kind of a scar tissue, which is extremely painful. We changed the bandage of Bente every other day under general anesthesia because there was no other way to do it without pain. And in between those general anesthesia moments, she was never pain-free, despite the enormous amounts of sedatives and pain medication that we gave at that time. Skin infections are the main cause of death. No growth because you lose too much energy. There's also a problem of the mucous membranes being involved. So the esophagus is blocked, so you need to feed through the stomach, through a percutaneous access, which causes problems in EB. And there is cocooning of the extremities. Here you see an example of how Bente's feet were deformed. The idea is that the toes and the fingers disappear. If you've ever seen an older patient with EB, you know that this is very, very severe disease. So the parents came up to us and they said, we've been on the internet, we know the diagnosis, and it's going to be worse instead of better. You have no treatment, which is true. And we see that she is never comfortable, not even when we are bathing her. So wouldn't it be better for her and for everyone to end her life and not forcing her to continue living until she dies within a few months? So please end the life of our child. That was the request of Bente's parents. And we didn't know what to do with it. It's a very uncommon request. And we, at a certain stage, said we can understand from a medical point of view, they're right, we have no treatment. We cannot take away all the pain, and it will get worse, it's true. But legally, there was no reason for us to be sure that we would not be prosecuted for murder. Because the penal code is simple. It says if you kill a person who doesn't ask for it, you're fucked. That's basically what the law says. And so we discussed who's going to be the doctor who does it. Nobody wanted to do it. We referred the patient back to the original hospital and said, well, we have the diagnosis, you asked for it, we have it, and good luck. Bente died 3 months later. She would have been 18 this year. And I wrote a small card to the father and the mother of Bente, and they replied on Facebook. They're extremely proud of their child. And you'll understand why in a few moments. So they asked for euthanasia, they didn't get it. Patient died, Bente died 3 months. The last 3 months were terrible. But when we heard about those last 3 months, we sat together again as a medical team and said, this was not good medicine. Let's try to find a way to do it differently if we get another Bente, which might never occur. But if there is another Bente, what are we going to do differently from this time? So we made a protocol just for our hospital. And we started doing searches, and turned out that there was a lot of literature available. There were even court cases in Holland from 2 doctors that ended the lives of newborns. One was a newborn with trisomy 18 who was at home, was supposed to die, but didn't die and had terrible suffering. The doctor ended the life, reported it. He was prosecuted. The second doctor was a doctor who ended the life of a person with spina bifida, who was not operated, had a giant hydrocephalus, and it became to be a terrible situation, so the doctor decided to end the life, reported it, and he also was prosecuted. And the verdicts of those 2 court cases were very similar. They said, if a doctor is with his back against the wall, if he can do nothing else than end the life to stop suffering, it's okay. So we didn't know that at the time, but those 2 court cases were very important for us as a knowledge base, because we knew that if we would stick to those requirements from those verdicts, the chances of prosecution would be practically 0. So we used all those informations and data to make a protocol. And it was published actually internally in 2001. And we didn't talk too much about it with other people. It was for us a way to make sure that the next Bente would get a different treatment. We were more certain that we would not be prosecuted. So if we as medical team would agree with the request, we would be able to go along with it. We also noticed that there were cases in the past that had never been published or never been talked about that were not prosecuted. This was an interesting sidestep. We went to the public prosecutor and told him we had Bente, we want to make a protocol. Can you guarantee us that if we stick to all the rules, that we will not be prosecuted? And at that time, the prosecuting officer said, I cannot say anything about future cases, so I'll see what happens if you present a case. That was very disappointing. But he was, the next prosecutor who came 1 year later, we went to him again, and he said, I think it is a good point. I want to see your kids. I want to see the way you work. I want to know more about what kind of diseases could potentially qualify for such a severe approach. And he also said, I know that in The Hague, in the central public prosecuting office, there are cases that have been reported to the public the prosecuting office. They were reviewed by those legal people and not prosecuted. You should be able to access those cases. And indeed, we were given access to those cases. We studied them. I have to brush. We studied them, we used them because we noticed that indeed 22 cases of, let's say, newborn euthanasia had occurred, were not prosecuted, but they were never, there was no public knowledge. There was no reason for anyone to publish it. But since we got access to those data, we had to promise to publish the analysis that we made, and we did. So it was a very much of help for making the protocol. The protocol basically says, if you have a baby just like Bente, who is stable, and you cannot withhold or withdraw any artificial ventilation because there is simply no ventilation, and there is unbearable suffering, etc., etc., you should be able to end the life if the parents request, but you should have it reported for review. And those are the requirements of the protocol. And you can see that they're almost similar to the euthanasia law that was made in 2002. The only big difference is point 3. Both parents need to be in agreement. When we published it internally, nothing happened. That was in 2001. There was a program on television who discussed parents killing their own kids because they didn't get enough help, and in that program, they referred to our protocol in Groningen. And I told them that indeed we had this protocol. We had a lot of help from the prosecuting office. And this was seen by journalists in Italy, Belgium, and Spain. And they started writing about it in a very unrealistic manner. So the messages that they sent out was, the Dutch have gone mad. They did not only legalize drugs and prostitution, they started legalize adult euthanasia. The next step is that they're killing babies, 350 every year. That was what was printed in both Italy and Spain. I have no idea where those numbers came from, but they copied the numbers from the other publications. And we were devastated because we didn't know how to stop this process. The Pope got involved. The Vatican has a journal which is called, it's on the left lower side, the Osservatore Romano. They wrote, in Groningen there is a program which is similar to the Nazi program, and the leader of the pact is Dr. Verhagen, who is just like Himmler. So that was really bad, and that was like attracting more media attention, and we didn't know how to deal with it. I got thousands of hate mails at that time, and I asked my hospital to take my mail account, filter it, and give me only the good news or the things I needed to know. And this was bad, and it changed when we published the analysis of those 22 cases in Dutch. It is this one. You will not be able to read it. When we published it on Saturday for the Dutch physicians, it is a Dutch medical journal, I was called on Monday morning by the editor of the New England Journal of Medicine. And he said, I cannot read Dutch, but I had a feeling that you have published an interesting article. Could you tell me more about it? So I told him about Bente, I told him about the protocol, and he said, you should write this down. And we did, and within 6 weeks, it was published. And when this was published, the New York Times came to us and they said, we want to appoint a reporter who will follow you for 2 days to find out whether you're either a Himmler or a good guy. And so we did. He followed me 2 days around on the ward, and he saw everything that I saw. He witnessed everything. And he wrote a satellite profile about me saying, there is something good going on in Holland, and we should be interested in the reasons why they are doing it. And that has really changed a lot. So the hate mails became fan mails. And although there's still a lot of criticism, things have changed really. And basically what people say is, as a criticism, this is a slippery slope. If you start killing babies for very imaginable good reasons, soon you will be ending the lives of those babies for less good reasons. And this is the slippery slope. Others say that will not happen. This is the only way. Legalizing it, organizing it, regulating it is the only way to get a shady practice above the table. Put the light on it. Make visible what is happening. Because if you don't do that, you have no control at all. And those Bente-like children, they exist. So what is happening to them in other countries? So the question was, of course, what would happen? Would indeed the slippery slope come, or would it turn out to be excellent choice in regulation, etc.? And the only way to find out for us was to gather data from our units to find out how many euthanasias are going on right now. And this is what we did. In 10 NICUs, we tried to find out how do babies die in those units, what are the decisions made, what happens actually when the tube is taken out and what medication is given, etc., etc. And we found that red bar and blue bar, half of the patients died because they were busy dying, they were very unstable. And the other half, the red ones, were babies who were not unstable. They were stable, actually. They could have lived on for days or weeks, but it was decided to take out the tube because of quality of life reasons. The future quality of life was considered so bad that the artificial ventilation was stopped and the baby died. We did it to find out about euthanasia, and there was one case only that we found. So a lot of data, interesting data we gathered. We combined this with a study that we did with Annie and Bill Meadow in other units to find out, are we the only ones who have the blue and red bars, or are other units doing the same? And it turned out that the biggest difference between those 4 units wasn't between the Groningen unit and, for instance, the US units, but it was between the US units, where there was one unit with only blue bars and another unit who had, just like here, a 50-50 division of blue bars and red bars. So we gathered more and more data. In the surveys later on, I have to rush a little bit, the blue bar, which is now a green one, disappeared gradually. So this was a sign that the numbers of euthanasia were decreasing and not increasing. And if we look at the 5 years before and the 5 years after the Groningen protocol, you would see that in the 5 years before the protocol, we have 15 cases of euthanasia. And in the years after that, there were only 2 cases. Both of them were EB cases. So the question was, how is it possible? Is it the legalization of newborn euthanasia only that makes the numbers go down? And the answer is no, it wasn't that. It was something completely different that we had not expected. Because in 2007, the Dutch government decided to allow all pregnant women to have ultrasounds at 20 weeks. And that wasn't the case before that, so it was for free. And before that, it was very, very limited, so limited access to 20 weeks ultrasound. Between 20 and 24 weeks, the mom, the future mom, can decide whether or not she's going to have termination of pregnancies. And in the numbers, the Dutch have registrations for everything. In those registrations, we see that after 2007, the numbers of terminations of pregnancies, specifically for spina bifida and other diseases, have increased enormously. So the work of the neonatologist became simpler. We see hardly any spina bifida cases or other severe congenital malformations simply because they're terminated. So it decreased, and the numbers have dropped even further. And there's a slide going to explain a little bit more about it. This is just to show you the analogy with the adult world. Started around 1985 when we first published euthanasia cases in newborns, surveys, court cases, the case of Bente, a protocol, and then in 2005 it was legalized, review committee was installed, a multidisciplinary review committee, and we survey and survey and survey to find out, is it increasing, decreasing, and do we need to have other interventions? What is happening to death and dying in newborns? So basically we have 1,200 deaths in Holland, and there is less than 1 neonatal euthanasia a year, which is very limited. We don't know how much requests there are, but the numbers have dropped considerably. We only know of EB. Until recently, last year, there was another case, which wasn't EB, it was a progressive neurodegenerative disease, a child that was crying all the time, and partly comatose, and the parents asked for newborn euthanasia, and it was done. And it was reviewed, and they were not prosecuted. So that was another case. Why so few neonatal euthanasias? I think that it has an interesting development, and Annie has pointed this out to me. This is weird. There is a legalization of newborn euthanasia. It is in place. If you want to use it, you can use it. But it's not happening. Why is it not happening? First of all, the Dutch doctors will do everything to prevent suffering at all times, which means that they would prefer at an early stage to withhold or withdraw life support if that's possible, because they want to prevent disabilities later on in life. It's probably also the reasons that we do not resuscitate babies below 24 weeks. We're very conservative there. It has to do with the same idea that you're potentially causing disabilities, and you shouldn't do that. So early withdrawal of care, also a big focus on quality of life and quality of death. Extremely important. Quality of life is the most important thing for doctors, and suffering is to be treated at all times and prevented. There are parental requests too. Parents ask us to early stop treatment because they don't want suffering in their child. And this might be different from other countries. Our parents simply are not, they're conservative too. So a very conservative group of doctors, a very conservative group of parents who will never ask us to do everything we can to save the child, which is different from many other countries and units. And if you ask me why is it, I don't know. I think it's a cultural thing. I'm not sure. So they will not ask us to do everything we can to save the life, but will ask us to do everything we can to stop the suffering. And there's also a labeling matter. If, for instance, a child is extubated and starts to gasp, parents come up to us and say, we cannot see this. We cannot stand this. Stop the gasping, please. Doctors, we have documented that. Then we'll say, okay, we can stop it. There's an easy way to stop it. We're giving morphine already. Let's give neuromuscular blockers to stop the gasping. So they give neuromuscular blocker, the baby dies. And for them, this is palliative care. There is a symptom, the symptom is to be treated, and neuromuscular blockers are excellent in treating gasping. So in their mind, this is not euthanasia, it's palliative care. So when we started to discuss it, there was a lot of confusion. Why are we discussing euthanasia in those kids? Because this is good medicine, this is good. And this is still ongoing. We have changed the neuromuscular blockers now for propofol and thiopental. And they're all seen as symptom management. If you have a poor symptom like convulsions, excellent way to treat it is thiopental or propofol. It will also stop the respiration drive, but that is not the aim. So it's not euthanasia. So there is a confusion there. And this might explain why the numbers are very low if you look at euthanasia as defined earlier. Okay. I'm not going to give you the example, I guess, because we have only very limited time, and I'm jumping to the summary and conclusion. End-of-life decisions have been studied in Holland for decades. We are obsessed with it, and we're monitoring constantly what happens in practice, newborns as well as older people. There is euthanasia for hopeless and unbearable suffering for adults. There is also euthanasia for hopeless and unbearable suffering in newborns. It has become rare. There are very few cases, focuses on prevention of suffering. Stop whenever you can, terminate whenever you can, just to prevent suffering. Public review of all cases, that is a very important element. So there's debate about a lot of things similar in adults as in newborns, and the regulation, the law, is similar in both groups. The difference, of course, is that the biggest difference is, of course, that you allow parents to decide on the death of their child, and that is really an ethical jump. The question in our country is, should we extend the Groningen Protocol to children who are older than 12 months? For instance, 13 months. Why would a 13-month-old baby be discriminated and not being allowed the same provisions as a 12-month-old baby? Same is true for 3-year-olds or 5-year-olds. And probably the same is true for 30-year-olds who are mentally incompetent, who are suffering. Are we going to allow a Groningen protocol-like approach for them? For the health lawyers, they say, if you have a Groningen protocol for 0 to 12 months, it is only logical that you extend it to 100 years. Because there is no reason to stop at 12 months, there is no reason to stop at 12 years. You should allow it for all mentally incompetent people. But this is a huge step that many political parties find very difficult to make. We are now almost at the end. We are now gathering data about the question, how do kids between 1 year and 12 years old really die in Holland? What are the problems that they encounter? And how frequently do parents actually ask for euthanasia in those kids? And we're going to publish the results in the next 12 months. And the bottom line is that requests for euthanasia in this age group are frequent and they are never rewarded. And there is a lot of anger there among parents who know about euthanasia. They've talked about euthanasia their entire lives. They have a kid that is severely suffering, and the doctor says, I cannot do anything because there is no law for children between 1 and 12 years old. So probably in the course of the next year, we'll be debating this, and you'll be able to follow it probably in the media again. Thank you for your attention.